This is the Equity Charter podcast, where we talk about why we care about equity in the digital health sector and why we think you should too. Welcome to this week's episode of the Equity Charter podcast. My name is Aisha Rahim and I'm a psychiatrist and Chief Clinical Information Officer working in the NHS. Along with my colleagues Hassan Chowdhury and Victoria Betton, we developed 10 principles for embedding equity within the digital health sector. This week we'll be looking at Principle 3, which is equity embedded into policy and practice. And here to discuss this topic with us today, we have our two experts, Marie Gabriel and Pritesh Mistry. Welcome to the show, Marie and Pritesh.
Thank you.
Hey, thank you.
So what we'll do is we'll kick off by asking you both a bit about yourselves and your current roles. If I start with you, Marie, can you tell us a bit about yourself?
Yes, so my name's Marie Gabriel. I've been involved in health in a social activist and a non-executive capacity for over 20 years, approaching 30 years. I currently chair NHS North East London ICB in the Race and Health Observatory, and I sit on a thing called the UK Health Security Agency as well. And I'm involved in two local charities, and that's all about furthering health inequalities through those.
Pritesh, what about yourself?
My background is engineering, so I come from a background that's quite technical, I suppose, engineering, tech development and research development in the NHS. So I started out doing engineering in life sciences applications, looking at very small things and then looking at very big things like galaxies. And then I got a little bit bored of that. So then I ended up trying to find what I wanted to do in life. And I found myself in the NHS, where I was supporting research development, research into clinical translation into spin-outs and IP licensing. So how do you get a good idea, build an evidence base around it, how to get that actually in use in a clinical setting, and then how to get that actually validated, quality assured and accessible to as many people as possible. So that's my background, and I now sit as a policy fellow at the King's Fund, a health and care think tank, where I do a lot of the research and development work around digital and health and social care. So what's the implications of technology at that point of care delivery? How does that match with the government expectations and plans, and how closely those two come together? So I do a lot of writing and talking to people, trying to understand what's happening within the healthcare system, what's happening within a government perspective, what's happening from technology, how those things kind of link together, and try and support people to have more of an awareness of where things are going, what are the challenges, what are the barriers, and how do we kind of work together to overcome those.
Fantastic, thank you. Okay, so we're talking about digital health equity in policy terms at the moment. So if we just take a step back, thinking about health outcomes, what currently do you see as the strongest policy levers for reducing health inequalities at the moment?
Looking at some of the changes that have happened most recently in the healthcare system, we've got a lot of flux happening and a lot of things that are under new structures and new ways of working that are emerging. Inequalities, I'd say, is probably one of the strongest levers that continues to exist in the healthcare system. So ICBs, and I think Marie would be able to talk much more strongly to this, but ICBs, even the new model blueprints, which were published last year, they've got a new remit, but they still have a strong expectation placed upon them to reduce inequalities. So to be able to look within the communities that they're serving and supporting, and be able to use that information and work within communities to try and reduce inequality. So I think that's probably one of the biggest levers that we have that's maybe reinforced through some of those changes that happened historically as well. I suppose looking back over the last 3-5 years, we've had the digital exclusion framework that's been developed, the core 20+5 model that's been developed as well. And those are things that should be embedded within how technology is developed and how it's implemented and used within the healthcare system, with an aim of reducing exclusion to targeting particular demographics who are at risk of worse outcomes than inequalities. I could talk a little bit more about some of the other stuff, but maybe if Marie's got anything to add on that.
So, yeah, I mean, I agree. As an integrated care board, with what Pritesh was saying, so definitely our four sort of statutory responsibilities, I reckon, are all about health inequality. So there's one around improving access, experience and outcomes from health services. There's one around wider determinants. There's actually one around value and productivity. And I believe that if you actually have tackle health inequalities, you have productive services that maximise value. So that's in there. But I'd also like to sort of take a little bit of a step back. And I think when we're thinking about policy within health, including digital, and we're thinking about that in terms of equity, we have to understand equity first. And we have to understand that inequity is systemic. And by which I mean it's deeply embedded in our systems, behaviours, processes, policies, written and unwritten policies in that, and our behaviours and practices and beliefs. And because of that, we actually produce and actually sometimes condone outcomes that are unequal and unfair. So when we're thinking about developing policies, those policies also have to be systemic as well. And and as health organisations, the NHS, which is one of the biggest employers in the world and definitely the biggest employer in Europe, you really have to think about all of the levers that you have, including those being an anchor organisation. And because I'm a chair, I think about things like governance and regulatory frameworks. I think about culture, as I think about corporate services and how they contribute to improving health equity, as well as about how we deliver our services so that they are more equal.
Yeah, and I think that's really interesting because there are plenty of levers out there and it's actually fairly mainstream. This isn't niche sort of policy directives that we're talking about here. But just kind of zeroing in a little bit into the digital side of things, Pritesh, I know you mentioned the digital exclusion framework. I'm just wondering, do we have other levers as well that help us when we focus on digital health inequalities too, that you're aware of?
So I think the digital exclusion framework is probably the main one. I think it needs to be linked across how the system works. As Marie mentioned, the governance structure, the procurement, how does that actually work with community needs, how we hear from communities and understand what some of those systemic barriers are. So I think that there's definitely more that needs to be done. We've got some of the frameworks, but it's actually... the policy is only as good as the paper is written on. It's when you actually implement it and try and make the change happen, and then how you go back to actually reassess whether that policy is effective or not, and how you adapt in a changing world. I think that's absolutely what we need to get better at doing. So we'll probably be talking about gaps a little bit later, but I suppose going back to what you were just asking around some of the policy levers and what's emerging, we see in the 10-year plan, for example, an opportunity in how we listen to people and elevate people's voices. And so that there's a refocus, I suppose, and an emphasis on people's voices, hearing from people and being able to use that information to be able to improve services. That's a great plan, but how that actually happens in reality is going to be the real test of that, and how we kind of listen and hear and respond to people that don't usually have a voice, and those people who struggle to access systems and services is going to be really important. And I think we've had long-standing challenges. So there's new targets that have been established around clinical trials, for example, and we know the diversity of people involved in clinical trials is poor. That has implications for the effectiveness and sustainability and suitability of these interventions. So going back to, again, what Marie is saying, some of this is systemic. So some of this is, we really need to think about how we configure the engagement and the processes and the development of technology from the get-go, from clinical trials, how we engage with people in a diverse way to make sure we've got new innovations that benefit a more diverse grouping of people. That then means that you have better outcomes and more reductions in inequalities further on down the line. I think this is really apparent when it starts coming to AI and data. I'm sorry, it's just the last point. So AI and data, I think, is really apparent in how we have an amazing aspiration around AI, but we're not really thinking about the data that sits underneath the AI. How are we improving that quality of data, the effectiveness of the data, the representativeness of the data? Because all that is going to then create biases in the AI system. And what we really need to be able to do is make sure that we're going from point of conception through to testing, through to actual deployment, thinking of inequities all the way through.
And I think it's also a continuum. It's not we're innovating and we're going to make sure that we don't have any sort of algorithms that have built-in bias, and we're going to sort of train staff. I think it is consistent, and that resident leadership, as we call it in North East London, is consistent. So when we were developing our digital policy and strategy, we worked with Healthwatch and other community groups on a community insights programme. So straight from the beginning, residents were defining what that would look like, and we're very clear from the evidence that we gathered the groups that we needed to target. So remember, I talked about intersectionality and the need to target groups. So, for example, carers were quite high up on that list, and also with refugee and migrant groups and others who live in sort of unstable housing because they just don't have access to those resources. But I think the other thing that was really important is that we continue to review what we're, so that whether we are equal. So we have what's called a digital inclusion forum that has everybody from community groups to people who are technical specialists, which definitely you can tell I'm not, and others, that they are consistently looking at what we're doing and whether it is impacted, and we're continually learning about how we need to change and adapt, particularly because our area is a very mobile population as well.
Yeah, and I just wanted to pick up what you had mentioned, Pritesh, and maybe, Marie, you've got a perspective on this. I think, and this is a thing that's come up previously on the podcast, when people hear the phrase digital health equity, they think usually almost exclusively about digital access. And of course, the inequities threaded throughout digital in all manner of ways. I'm just wondering, from an ICB perspective, how much do you think it's on people's radar about all the multiplicity of ways in which inequity threads itself through digital transformation? So I'm thinking about product design, research, again, as Pritesh was saying. How much does that feature in people's thinking, would you say?
So definitely the primary motivator in the beginning was around how do we deliver accessible services, but as soon as you start to have that conversation, you start to actually think, well, how are we going to do this? How are we going to design? Who do we procure? Who do we partner with to design? How do we do this in an integrated way? So that, so one of the things that came from the insights is that people want to be able to access the same sort of system, no matter who the provider is, who's involved in their health and their care. So you can't just leave it alone. And if you're thinking about implementing it, then you do have to think about workforce as well, and you do think about your academic partnership. So it's not you can't do access to services without thinking in the round.
Yeah, and it feels like a ball of wool. If you pull the string, you sort of start to unravel a whole bunch of other different things to consider as well. It's really interesting. One of the things I was also thinking about is how we strike a balance between thinking holistically about the impact of digital transformation, its impact on equity, but still making the NHS a place that suppliers want to innovate in and want to do business with, because they often feels like a bit of a tension, because we don't have the solutions that we need currently to address the massive demand that's out there with our current level of resource. And I just wondered if you had perspectives on this, Pritesh.
So, yeah, I think it's about how we work in partnership. So a lot of it is around partnership work. It's partnership working with communities, it's partnership working with industry. It's recognising that everyone's got a perspective and skills that they can bring to the table, and we can solve problems together. So a lot of our work that we've published last year around digital exclusion and inclusion, it focuses on how we work within communities, how the NHS doesn't need to do this alone, how some of the work that is really moving ahead is when charities, communities, local authorities, NHS and industry are able to come together and help to solve a problem and improve services. And that takes different ways of working. And yes, there's a lot of, I suppose, criticism and frustration in trying to work with the NHS, the speed of it and all these other things. Mm-hmm. But there's also, a uniqueness of insight, of clinical suitability that the NHS brings, a trust element that can bridge into communities, and charities are able to really help engage within communities. So I think it's for from the work that we've done, a lot of it is around partnership building, partnership working. It's about building places of shared power. So NHS organisations not saying, come to us, we want to talk to you about the NHS app, but actually, can we come to your cafe? Can we come to your tea mornings? Whatever it might be, we'd like to hear from you about your experience with NHS services. We'd like to give you share with you some things that we're thinking about and get feedback so we can actually move forward in a way that works for the communities. So that's where we feel there's a lot more opportunities to work together. And in doing that, what we think is the impact is the move towards outcomes-based commissioning that's coming through, the move towards more productivity, more improvements in how healthcare is felt and impacted. So that means that the technology needs to meet people's needs and solve a problem. And if it can't happen by a tech provider just developing something in isolation in some corner, it needs to happen in a community.
And I absolutely agree with that. It has to be a multi-stakeholder approach and sort of led by residents. But also, sort of if I'm thinking about it as a chair of a board, I'm going to be thinking about clinical leadership, the clinical impact, financial viability for us would be a prioritisation sort of in that priority matrix, technical feasibility, strategic alignment. Those kinds of things are going to be really important in terms of effective prioritisation for us as a board. And because we won't be able to do everything, and it is when you're somebody within the health service. Recently, London People Board, we had a sort of digital focus, and there was so much. You really have to think about what are going to be the high impact, meaningful problems that digital is really going to help you with. And that's across the board, because like you said, it's not just about access. So how's it going to help us with workforce and the challenges around workforce and burnout and stuff like that? How's it going to help us with our operational efficiency? So we did lots of work around HR efficiency when in another organisation I was involved in. So I think it's really, in that prioritisation, it's got to be real to your community, it has to be real to your organisation, and it really has to help you move forward in a measured way.
No, that's really, really interesting. And I'm just thinking about the fact that, we've painted a picture of what should happen, what things look like when we're doing this well. What about when it doesn't work well? We've got examples of this, of course, but where does the accountability lie when we have ended up implementing something that actually widens those inequalities rather than improves them? Because at the moment, it doesn't really feel necessarily very clear to me. I'm just wondering if you had perspectives on this.
Well, I think what we've been saying, Pritesh, is that health equity, including in digital, is everyone's business. So if you're going to really implement your health policy well, you're going to make sure it's embedded in all your policies, from job descriptions through performance management to KPIs and everything. But ultimately, I would say this, being the board chair, I think it lies with your board. Mm-hmm. Because your boards of health organisations are responsible for setting policy and for overseeing that policy implementation and ensuring that whatever strategy we develop is landing in the way it should do. So it's senior leaders, I think, ultimately, because it's about the culture of your organisation, isn't it? And creating that culture where everybody has the skills and knowledge, but the excitement around using digital to improve health equity. So I would definitely say it sits with the board.
So I agree. I think there's absolutely accountability and leadership that should sit at the board level, and a board level that is able to, it doesn't mean that the board needs to be digital experts, but they need to be able to champion digital, be able to ensure that it has prioritization, be able to protect budgets. We often hear about tech budgets being raided, but like Marie says, it's every part of the job descriptions, the training, as well as buying the technology. So it's every part of how a system is configured and run. And so absolutely, I think it's accountability and leadership at a board level, but then also leadership, like Marie mentioned, clinical leadership. It's leadership at different levels as well, to make sure that the culture shift and the ways of working kind of throughout the system and the organisations. And some of that is also role modelling. So some of our work, some of our conversations that we've been having, chief execs ensuring that they protect a day a month and going out into communities and hearing from people and listening and demonstrating to their workforce that this is important. They protect the time to do that, and they are going to do that. And that's visible, and that's really important. And then it's making sure that staff have the skills, the confidence to be able to engage in communities, the time to be able to do that, that it becomes a real part of their everyday work. So whether that's observing a waiting room and understanding how people are interacting with the system in that environment, or going out to communities and listening to people, but being able to have that as part of their just understanding of some of the fabric of the system and how that can exacerbate inequalities. And lastly, I've touched on this before, but moving away from this is our 5-year plan and we're going to stick to it and this is what we're going to do, to actually, we know some of the technology implications, but we don't know all of the implications. And society is changing and the world is changing. So we need to be able to adjust as we go. Mm-hmm. And there are going to be positive implications as well as negative implications. And how do we continue to assess that and adjust as we go?
I think that's really true. I think that flexibility and risk is an ongoing discussion at each of my boards around digital. But there's also thinking, I think a lot, which I forgot to say earlier, which is around, does it integrate with other things we're doing? That kind of interoperability point is a real challenge. And when we're working with partners, they usually come from a product that is their product. And we have to think about, well, how's this going to fit with what we're doing already, or improve on what we're doing already?
As a CCIO, this is a very familiar sort of term that I come across, so I can very much relate to that. I'm interested in where supplier responsibility lies as well, and accountability. And I just wonder whether this is one of the gaps that we were talking about at the top of the episode, which is, do our policy levers, they talk about supplier responsibility, or is it just focused on the NHS? I'm just wondering about perspectives on where our commercial colleagues sit in all of this.
Well, I think that is a partnership, because it goes back to, don't just produce something and think that we're going to want to use it. Actually, you need to work alongside us to deliver a solution that works for us both, and actually is commercially advantageous to you, really. In that same. So I think it is, and actually I'd put in that, because thinking about that digital inclusion forum, that's also got academic partners in there as well. So you're always thinking about innovation and change, but has, sort of someone from HR, because it's also about the change management that would need to happen with your staff, not just the technical skills that they have, but, so yeah, I think it's really important that you see the relationship not just as a strictly, sort of like purchase supplier one, but a partnership. But that also means for me that you have to be really clear about who you're partnering with. So my expectation of suppliers is that they also understand equity, that they live it within their organisations. And it's a key part of what they do before they even come and talk to me about working in partnership with my organisations.
And I think sometimes it's easy for conversations like this to feel a little bit intangible at times, but we've got some very real, fairly recent manifestations of discrimination within health technology. And I'm thinking particularly, Marie, about the work that the Race and Health Observatory did around the pulse oximeters and the COVID pandemic. And I just wondered if you wanted to say a little bit about that.
Yeah, no, of course. So we were getting feedback at the Race and Health Observatory from people in the community and from some clinicians that pulse oximetry, which is the thing you put on your fingers to check your breathing, is not working so well for darker skin tones. And so we quickly did a rapid review into this and actually found that this was the case. But what the Race and Health Observatory does is it gathers the evidence, sort of translate that into policy and implement and uses that sort of like for practical recommendations and support that implementation. So from that, basically NHS England, by the July, so this was published in the April, by the July, NHS England, and I think then as well there was NHS Improvement that hadn't come together, reviewed the recommendations and actually produced new guidance that had to be abided by clinicians. So we weren't telling people to stop. So anybody listening to this who've got darker skin tones, do not stop using them. But there are additional things that you had to consider when you were using those. And it actually led to a review by the then Secretary of State for Health, which was, I'm trying to remember which one it was. I think it was Javid, to do a review of all medical devices that led to findings and recommendations, including in terms of AI, for example, and data. So it's, by doing one intervention, how that can actually be used and developed for learning to look at other areas is a really good exemplar of the importance of a really sort of sound digital policy, and also the flexibility that Pritesh was talking about earlier.
Mm-hmm. And I think it's such a powerful example about the real life implications of everything that we're talking about here. And, I think we're well versed on the potential impact from a health perspective, but it also has a financial impact as well. And again, I know the RHO has done work on quantifying the cost of racism within healthcare. And I just wondered if you could tell us a bit more about that too.
We all know about the moral imperative to address racism, but we are in a sort of economic situation. There's a real focus on economic growth with successive governments, and so we wanted to understand what the economic cost of racism was, and in terms of how it affects NHS individuals and wider society. So we produced a first paper that basically gathered together the evidence around the present financial argument to address racism, because not only does it harm individuals, but actually it places a significant economic burden on the NHS and actually on the wider economy. And that's led us to, because there are gaps in knowledge, to commission sort of like a longer piece of work, a multi-phase study, quite a major study, to quantify the economic, social and healthcare costs of racism in England. And I think that's really important, because that will help people understand the value of the interventions, and actually how, and we're going back to what I said about, ICBs, the strategic commissioners have a responsibility to improve productivity and value. This would be a really important tool to help them to make decisions.
Yeah, I think so. I mean, we, as you say, we talk about the moral case for diversity and inclusion, but actually there's a really quite a strong business case for this as well. So I think it's kind of important that we all sort of recognise that aspect and actually are able to put some numbers against that. Now, this wouldn't be a digital podcast if we didn't talk about AI. So everyone is talking about AI these days, and those tools are proliferating everywhere. So Pritesh, I just wondered if I could come to you for a second. So we've talked about some of the policy levers around inclusion and representation, but the pace of change, obviously, with AI is so stratospheric. Regulation is really struggling, isn't it, to keep up with this from an information governance perspective, from a clinical safety perspective. What awareness do you have of where these conversations are taking place about mitigating the bias within these foundational data models, and how do you think regulatory processes should address this?
So there's different types of foundational models, right? So some of the stuff that's really hit the ecosystem more recently is ChatGPT and Claude now have health modes available in the US. We're expecting them to come over to the UK shortly. People are already using these state-of-the-art foundation models for health guidance. And I suppose we need to have an understanding that those are consumer technologies that are not health technologies. And we're still trying to figure out how to regulate those. And because the consumer technologies, they basically have a disclaimer, which I would say isn't good enough. And there's a need for policymakers to work with tech suppliers to understand how we build public awareness, knowledge and skills to best use these tools. I don't think we're really talking to people effectively to understand where are they finding value in these tools, how do we support them to use them effectively, how do we make sure there's the right guardrails in place to stop inappropriate usage of those kind of tools. And then there's the actual specific AI medical health tools that are regulated. And I suppose the challenges that we're facing is the technology is moving so fast compared to regulatory processes that we really need to start thinking about how we regulate differently and how we can regulate at pace and make sure we've got the right systems in place to be able to validate the models. And that's all still under development. And as that's kind of evolving, we've now got an emergent area of AI, autonomous AI, so AI that doesn't have a human in the loop. And that is creating all sorts of other kind of concerns around the inbuilt bias in the systems and how that might potentially propagate if you don't have a person overseeing the AI. So I think this is all a very emergent area, and there's a lot more that we need to do. And we need to, I suppose, for me, a lot of it comes down to how do we work with communities? How do we make sure that we've got the right systems in place? How do we move away from people checking everything to having the right validation across a whole bucket of technologies, as opposed to individually testing one technology at a time? How we stress testing the validity of technology against a community diversity, how we ensuring that it's from, as I mentioned, from conception to implementation. So going from actual concept of an AI tool, the data that's in use, how is that actually from get-go incorporated into the design of a technology to ensure that the structural inequalities and the data that represents the structural inequalities in the system aren't propagated through AI tools. That is all under development. I think there's a lot more that we need to do and a lot more visibility that needs to happen around that.
Yeah, and it's really interesting, isn't it? Because and I'm sure you both see this as well, but there's so much in many quarters, interest, enthusiasm, the lure of AI, given our productivity challenge at the moment, and tempering that with the gap, I suppose, in knowledge and understanding is one I think we are still in the process of trying to bridge. And it's what happens in between those times while we're bridging those gaps. So it feels really interesting / scary. I don't know, pick your word of choice, I suppose.
Absolutely. I think there's a whole spectrum of emotions that it brings up. But I do think there's a huge opportunity to rebalance some of the power within the healthcare system. How do we move away from a paternalistic system? Some of these tools that people are using to help them have more informed conversation with the healthcare system, to have more choice and be more empowered. I think that there's a huge opportunity there. But there's also massive risks that you kind of outlined. And if we just start putting technology into place, and we know how long technology sticks within the NHS. So early stage technology that isn't effective, that could widen health inequalities, that stays in the system for 10, 15 years is not where we want to be. We need to be able to assess, adapt and move forward.
So assuming we have appropriate policy levers in place, I just wanted to talk about how we move into translating that into practice. And I'm just wondering if you had either of you perspectives on some of the challenges in making that leap.
I think these are the kind of like maybe some of the same challenges we've identified before in terms of translating to practice. It is about that cultural change. It is about ensuring that both our communities and our staff are ready and able. And we know in terms of equity, many of the communities that we work alongside already have a mistrust of health organisations more generally, public services, but they also have a mistrust of tech and whether or not their data is going to be secure. And so, that co-creation, I think, is really important. I think it's also actually about making sure that we have good change management. And sometimes people forget about that in place within our organisations. And remember, I'm thinking about it being everybody business. So I'm thinking about corporate sort of areas as well as delivery of care areas, as well as our innovation. I think and some of this translation in practice is about, as policy changes, it's going back to the flexibility point that we've been making, that policies aren't, that's it, we're just leaving it alone. You're consistently and continually reviewing your policies and the strategies that emerge from those to make sure that they are relevant, because this is a field that is very busy, moves rapidly, and trying to get your hands around it is very confusing. So I think that's really an important piece, perhaps more than other areas that we're traditionally used to in health, I think. So I think it's sort of that translating into practice is a usual way in which you translate policies in practice, but also thinking about the changing nature of technology and the need to be flexible in response.
Yeah, I'd completely agree. I think a few other things that are kind of popping up for me is the culture shift. I think is particularly important, and a lot of our work around digital exclusion. There's assumptions who will be excluded, and those assumptions aren't always true. Older people will be excluded. And that isn't necessarily true, right? So anyone can be excluded at any one time. We've seen an increase in digital exclusion with the cost of living crisis as people are unable to afford their mobile phone kind of tariffs, for example. And so it's about trying to meet people where they are. It's about listening to people. And a lot of people are willing to try technology, but they need the support to be able to try the technology. And if we don't have the right workforce and the right skills and the confidence within the workforce to be able to support people, then that's automatically a gap. So about translating policy into practice, it's around having the skills, it's around engaging with people where they are and listening to people and being honest with people. So when you're co-producing, it's not, say, offering the whole world, but actually being honest and open with people that these are the constraints, this is what we can achieve, and this is what we want to work with you on. And often people will try and give you more than that and will be very generous with their time. But you need to be able to give respect to that and listen to people and say, this is what we've heard and this is what we're changing in response to that. It's not just going into communities and ticking a box of saying you did engagement and then going away again. It's a continual process of building that trust and building that bridge with the partners and the people involved. So I'd like to say that I think that's really important. One other thing, going back to the Pulse Ox example, I think there's a lot of different ways that inequity can rise within the healthcare system, as Marie's kind of mentioned. One thing that jumped out to me recently is some of the educational images that are used, for example, for sepsis, and how they are not diverse at all. And when people are trained in a particular limited educational information, let's call it, then that means that they only have expertise in a very narrow domain with a very non-diverse group of individuals. And so things like sepsis, skin cancers and melanomas and all these other things where you have a very small range of educational material, then that means it has implications for how healthcare is delivered and the inequalities that arise from that as well. So it is an end-to-end approach that we need to consider as well.
And there are some challenges, of course, in that, which is why the partnerships for digital inclusion is really, really important. The resources we have, we do have limited resources. So how you can best deploy those, which goes back to earlier conversations about the decisions that you make, and actually how you can work with others. So so you get the benefits of that joint work and economies of scale are really important, particularly that partnership with the commercial sector who can bring resources in. I think sort of carefully sort of boundaried and so on and so forth. But I think that is really, really important to recognise that there will be some challenges. So when you're translating that policy, think about the risks around that and think about how you can mitigate those, but also areas where you can maximise opportunity.
And of course, again, the RHO has relatively recently published its 7 principles for anti-racism. So if people are looking for a place to start with this, then that might be one area to look at. And I know that that's started to be adopted elsewhere by the CQC, for example. But I just wanted to ask, Marie, why did the RHO feel that it was important now to publish something like that?
Well, I know it's not a now thing, to be honest. It's not a now thing. So what we've found for a number of years is that people in leadership roles will say, I don't know how to do this. I've got no idea how to do this. And so we wanted to have something that was quite straightforward in terms of this is how you as a leader can ensure that you are implementing sort of equitable practices. And so we developed those 7 principles with an infographic, but also 7 sort of like briefings for each of those principles about how they may apply. And we're really pleased that, that people are beginning to adopt that, from the CQC to the National Lottery Community Fund, as a way to sort of assist people to think about how they approach being anti-racist organisations and anti-racist leaders.
And similarly with the King's Fund, Pritesh, of course, there are lots of publications out there that are published by the King's Fund. Is there anything in particular that you would point people to in this realm?
So, yeah, we've published a little bit of work around digital exclusion over the last few years. I'd point to probably our more recent publication in 2025 around digital co-production and working within communities and in partnership to be able to create more accessible services. So a lot of our work shows that even people who are very digitally able can find the accessibility features, for example, within digital tools and technologies in the healthcare system exclusionary. And so while they are able to shop online and do their online banking, they're actually excluded from healthcare services, so they don't get the benefits that they could do. And some of these people, they are physically excluded as well. So we've talked quite a lot about digital exclusion, or at least I have, but I think that there is we need to be considering that there are people who are physically excluded as well. And if they're digitally excluded and physically excluded, then they are really at a disadvantage of being able to access healthcare services. And so it's about equity overall and how we create accessible services that work well for people. And digital has a unique offer as well, right? So things like sexual health, for example, is very strongly aligned to protecting people's privacy, being accessible, and things that are really work well for digital tools and other kind of conditions that might be associated with stigma and etc. So I think that there is a real opportunity for digital to level inequalities in many different ways if we can get it right.
Fantastic. Okay, and so the last question, just to round us off to both of you. Do either of you have specific thoughts, if you're speaking to policymakers or if you are a policymaker, what is the most impactful area that we should be focusing on first, do you think?
I try and veer away from silver bullets. So I think it's always going to be, for me, about how we shift a culture and a way of working, that we are working alongside people, we're sharing power, we're able to continue to reassess our assumptions and improve what we're doing.
So, yeah, I think if I'm talking to national policy makers, it is perhaps about the investment that they place. So also in terms of those regulatory frameworks, what they emphasise in terms of what we're judged on as healthcare providers. So I do agree the internal thing, but I'm now trying to think externally, and so that they do help us to invest, but also that they have that expectation of us as leaders that we will have really effective digital strategies that embed digital inclusion in the widest way possible. I think that there's all sorts of things they can do. I mean, sort of which you've got the framework, but I think there's some stuff around that we've been striving for in the NHS is to draw out the best practice of what works and sharing that, learning across, and perhaps enabling that joint working. So in London, we're working all together as ICBs on digital access and looking about how that is something so that we have one standard across London. So wherever you live in London, you'll have this digital access. So I think, just thinking about those national levers that we can utilise.
Brilliant. Well, thank you both for a really stimulating conversation. All that remains for me to do is to once again thank you for your time. Thanks, Pritesh and Marie. Thank you for tuning in to this week's episode of the Equity Charter podcast. Don't forget to rate, review and subscribe to the series. And if you'd like to know more, go to our website at www.equitycharter.digital. You can follow our page on LinkedIn, join our community of practice, and you can also contact us at hello@equitycharter.digital.